Hello everyone. I hope that you all are doing fine. So we will start with today pages in which we are mainly covering the periodontal and peri-implant diseases. Okay. So firstly, we will start with the gingivitis, which you all know it is the inflammation of the gingiva. Is the most mild and common form of periodontal disease because uh, this is the thing from where the periodontal disease start. Later, it can progress into periodontitis. There would be recession. There would be tooth movements and all of the other things. But the starting point is from gingivitis. Then they record the periodontal status of all patients because approximately 50% of the population have periodontal disease. So when a patient comes to you for a checkup, you also look for like the caries, decays, you do the biting x-rays, you also look for hard tissues and soft tissue. Along with that, also check their gum health with the probe because it is very commonly seen, the gingivitis. Gingivitis is associated with the accumulation of plaque. So, as we all know, we studied in the caries chapter that plaque is the main cause of caries. Likewise, for gum issues, also the dental plaque is the most important cause, which is a complex biofilm of mixed bacteria and their byproducts. And calculus at the gingival margin. Bacterial byproducts diffuse into the adjacent gingival tissue, causing a non-specific inflammatory response. So, gingivitis itis means there is an inflammation. It is caused by the bacteria present in the plaque and their byproducts. So, like, just keep in mind the plaque is the main reason behind anything that you commonly see in your patients. Like, even it is decay or it is gum issues. The inflammation of the gingival tissue results in red and swollen gums that bleed easily. Gingivitis, it is not painful. So, whenever the patient comes to you and it is very hard to explain to the patient if they have any gum issues because if there is a decay and reaches the nerve or the patient would feel the symptoms. Like, firstly, he would start to feel the sensitivity, and later that would progress into pain on biting or any infection. But for the gum issues, as it is not a painful condition, so it is very hard to explain to the patient. And it does not destroy the pedial or alveolar bone. So as we all know, if there is a destruction of the pedial ligament or the bone, then it would changes into periodontitis. However, if it is not managed appropriately, gingivitis can progress to periodontitis. And we will look at the diagram where they have shown the location of the gingivitis. With appropriate management, gingivitis is reversible. What is the main management for the gingivitis? Is the removing of plaque and calculus with thorough debridement, means with the scaling appointment, and smoothing. If there is any area where food is getting stuck, then in that area we need to clean it thoroughly or remove the irregularities, and improving oral hygiene through patient education, which would involve brushing and flossing. And if the patient has a larger gap in between his teeth, he can also use the interdental brushes. Okay, and the recovery is expected to be seen within 1 month of time. Antibiotic therapy is not required for gingivitis because this is not an infection, this is an inflammation. If pain and inflammation associated with gingivitis restrict oral hygiene practice, consider short-term use of a generally with the gingivitis there is no pain. But in any case, if the patient complains that he's having pain from his gum and that's the reason he could not brush his teeth properly, so we can prescribe him chlorhexidine mouth rinse, but only for a short duration, which is 5 to 10 days. There are two composition as we read in the previous chapters, which is available in the market. One is 0.2%, and other one is 0.12%. For the 0.2%, as its concentration is more, so need to use only 10 ml rinsed in the mouth for 1 minute and then spat out. Okay, 8 to 12 hourly for 5 to 10 days. But for the chlorhexidine, which is 0.12%, its concentration is relatively lesser than this one. So you can ask your patient to use 15 ml rinsed in the mouth for 1 minute, then spat out, and 8 to 12 hourly for 5 to 10 days. Okay, so for the gingivitis, it is bit simple, which means that you would be checking for gingivitis in any patient who would come to you for checkup. Then it is not painful. A patient would just complain about bleeding gums mainly, the sign which we commonly see, and the regression would be expected in 1 month. And you need to take several steps, which means the regular cleaning, smoothing any areas where the is getting accumulated, and the oral hygiene instruction. Then periodontitis, its next stage. Periodontitis is characterized by the loss of bone and tissues that support the teeth, which means pedial formation and periodontal pocket formation and gingival recession. So these are the type which is periodontitis. It is often associated with halitosis. In periodontitis patient, the signs would be halitosis and an unpleasant taste in the mouth. Because in periodontitis, there is loss of bone and there is space between the tooth and the gum tissue. So in that space, which we called as pocket, food is getting entrapped and bacteria are acting on it, and that's the reason it is progressing. But due to this process, it would also lead to bad breath and bad taste in the mouth. In severe periodontitis, the tooth would be wobbly, allowing space to develop between the teeth, and there would be much space and tooth would be wobbly. So for periodontitis, for gingivitis, there was only the signs like patient would complain about bleeding gums, and in periodontitis patient can complain about bad taste, bad smell, and wobbly teeth. Pain is not usually a feature until a late stage of the disease. Assess and record the periodontal stages of all patients because approximately 50% of the population have periodontal disease. Then gram-negative anaerobic bacteria are involved with the initiation and the progression of the periodontitis, which is the main type of bacteria which is involved in periodontitis is the Porphyromonas gingivalis. Then there are certain risk factors. So this is the cause of periodontitis, okay? So the cause is this bacteria, but there are certain risk factors. If these risk factors are present in any patient, it would increase the development and the progression of periodontitis in those patients. Okay, so which are main risk factor? Which is smoking and poorly controlled diabetes. So here the main what thing you need to put focus is if the patient has poorly controlled diabetes. It means if the patient has stable diabetes, that patient would be equal to as the normal people. Okay, so only in case of poorly controlled diabetes and smoking, the risk of periodontitis increases. Periodontitis is classified by its stage and grade. So staging means severity of the disease and complexity of treatment, and the grading means rate of progression. We all know about these staging and grading now, right? So there are certain stages from where we like divide the case, like according to the amount of bone loss present in the x-rays and according to the number of teeth which patient may lose due to periodontitis. And the grading means as respect to the time, how much is the progression of the disease. For example, if the patient is smoking more than 10 cigarettes and he has diabetes, then the rate of progression would be much higher than the patient who does not have these factors. And it is also calculated according to the age as well. So there is different classification. um, and if you have any doubt, I can surely help you with that as well, maybe later. Then the disease usually presents as chronic and slowly progressing with brief acute episodes. And the amount of plaque, calculus, and bleeding usually corresponds with the disease severity. How much is the amount of plaque present would be like, it does depend on how much severe the disease would be in that patient. And this periodontitis, it is generally chronic and slowly progressing. It has brief acute episode, but generally it's slowly progressing. It's not an acute condition. Rarely patients present with the rapidly progressing forms of periodontitis, which was previously known as aggressive or early onset periodontitis. It is characterized by rapid attachment loss and alveolar bone loss. So this rapid form we generally see in young people, but generally the most of the time periodontitis happens as a chronic, which we commonly see in old people. Okay, so in rare situation, some youngster can also get the periodontitis, and it is called as rapidly progressing periodontitis. It is characterized by rapid attachment loss and alveolar bone destruction. Unlike the usual presentation, the severity of periodontal destruction does not correlate with the amount of plaque and calculus. This presentation is more common in patients with the family history of the condition. So it generally runs in the family. If there is any family history of the gum condition, there is high chances that the kid can get the rapidly progressing gum issues. And in this case, what is the most important thing is, as we read here, the severity would depend upon the amount of plaque calculus present. But here, you would see in your patient the gums would look clean, but there would be much amount of bone loss as compared to the plaque present. So that's why it is rapidly progressing. And this presentation is more common in patients with a family history and specialist management of and for these patients you won't be doing anything. The specialist management would be the best option for them. Okay, and this is very rare to be seen, but there are certain situations and certain scenarios. I think one or two scenario where they do ask about the rapidly progressing gum issues. Then periodontitis in children is rare and usually associated with systemic diseases. For example, if if the kid has leukemia, type 1 diabetes, and cyclic neutropenia, then it would causes periodontitis in children. But although it is very very rare, okay, and then refer for urgent specialist review. For these children, if they have periodontitis, for them you need to refer them urgently to the specialist review. And for the other patient, if you see the rapidly progressing form of gum issues like in adolescence, then you need to just refer them to the specialist. But here the referral is urgent in children. Then successful management of periodontitis requires, what is the best management of periodontitis? It means for like for everything, if you want to manage e- anything, the best solution is to remove the cause. What is happening? Like why it is happening? So what is how you can remove the cause? Removal of bacterial deposits, okay, which you will do by doing the cleaning. And then improved patient oral hygiene, which patient would do by doing brushing, regular brushing and flossing. and control of risk factors, which are smoking and poorly controlled diabetes, and continued follow up for periodontitis or for any gum issues. It is very, very important, the review, which means if the patient has uncontrolled gum issues, then you need to see the patient every 3 monthly, and if he has the good oral hygiene or if he has the normal oral hygiene, then you can see him every 6 monthly. Thorough debridement to remove supragingival and subgingival plaque and calculus, LA may be needed, because if you are going subgingival, it would be sensitive for the patient. So sometimes you may need to give LA to the patient. And polishing, reshaping, or replacing defective fillings, like same as gingivitis. If there is any place where you find that there is a space where the plaque is getting entrapped or food is getting entrapped, in that case you can polish it or reshape or replace it, that filling. Then providing patients with advice on oral hygiene. You need to, this is the patient part, which is the brushing and flossing. We will read in this page, 273 page, in more detail, but the main thing is the brushing and flossing. 2 times brushing with the fluoride toothpaste for at least 2 minutes, and the flossing should be done ideally at the night time before brushing. Then collaborating with the patient's medical practitioner to modify risk factor. So with the smoking and diabetes, you cannot do anything, right? So you need to collaborate with the patient's GP. And providing regular supportive periodontal care, it means you need to see your patient more regularly if he has the gum issue. For patients with severe periodontitis, specialist referral is usually required. Periodontal surgery may be indicated if the patient has not responded to non-surgical debridement. All right, so you just need to do these 5 points for the patient. This is the only thing which a general dentist would do. Even after doing this, you see that the patient is not responding or it is not helping him, or if the patient is not happy with your treatment, then the option that you have is the specialist referral. Okay, because they may need to do periodontal surgeries if it is indicated for the patient. And antibiotic therapy is rarely required for periodontitis. Only consider antibiotic therapy for the following patients, preferably under the care of a periodontist. Okay, so it is very rare case we prescribe the antibiotic for periodontitis. Okay, only in certain situation, only in these situation, they do prescribe the antibiotic, but which is also prescribed by the periodontist, which is the specialist. So in brief, you won't be prescribing any antibiotic to the patient in case of periodontitis. Okay. So, which are the cases where specialists may need to prescribe the periodontitis is patients with rapidly progressing periodontitis, then patients with periodontitis that has not responded to dental treatment, and the immunocompromised patient, including patients with poorly controlled diabetes. So, if the patient, here the risk factor, if the patient has poorly controlled diabetes, you did all these 5 things, but still the patient is not responding, then you need to refer the patient to the specialist, and he may need to prescribe him the antibiotic, because poorly controlled diabetes can impair his immunity level. Okay, then necrotizing periodontal disease. It is an acute painful condition. It is very painful condition. So the gingivitis and periodontitis was not at all painful, but this is very painful condition. Characterized in this condition, patient would complain about gingival bleeding and necrosis or ulceration of the interdental papilla, which is often covered with the grayish pseudomembrane. It is usually associated with the halitosis, which means the bad smell, and can be associated with swollen glands. Okay, so if you try to palpate the the glands, they would be swollen and the patient would have fever. So it means the patient would have the systemic signs. Necrotizing periodontal disease is classified by the extent of inflammation. So it is classified into 3 stages, and the basis is on the extent of inflammation or necrosis. So if the patient has necrotizing gingivitis, which was previously known as ANUG, only affects the interdental papilla and the gingiva. If it is not managed appropriately, it can involve and spread to the bone. Then it would be called as necrotizing periodontitis. For management of necrotizing gingivitis, we will read in next page. Necrotizing gingivitis it is most commonly seen in young adult smokers and rarely occurs in children. Okay, so there is one scenario about this case also, and it is most commonly seen in young adult smokers. And children taught to have necrotizing gingivitis should be assessed for acute herpetic gingivostomatitis. If there is any symptoms like fever or halitosis or any symptoms like these, if you are suspecting and he's a kid or children, then always rule out acute herpetic gingivostomatitis, because that is more common as compared to in NUG in children. Then necrotizing periodontitis, it affects the periodontium and results in bone loss. Promptly refer for specialist management. So you would, as a general dentist, you would only be treating if the patient has necrotizing gingivitis. If the patient has necrotizing periodontitis, just refer him to the specialist. If the patient has necrotizing stomatitis, which means it has now spread to the periodontium, the bone, and the soft tissues as well. So now promptly refer for specialist management. So in these two cases, you won't be doing anything. The area of your concern as a general dentist is only necrotizing gingivitis. So how would you manage if the patient has necrotizing gingivitis? The main reason is the thorough debridement of plaque, because that is the cause, and necrotic debris is necessary for successful management of necrotizing gingivitis. However, it may not be possible to complete the debridement at the initial presentation because necrotizing, because in gingivitis and periodontitis, as it was not painful condition in the first appointment only, we can start with the cleaning or scaling. But with this condition, patient would be in so much pain, it would be really hard for you to do the complete debridement. So begin your management with these steps. Firstly, gently try to remove as much plaque and necrotic debris as you can, and using LA if necessary. Then locally irrigate that area with chlorhexidine 0.2% mouthwash, or you can use hydrogen peroxide 3% solution. Chlorhexidine mouthwash or hydrogen peroxide solutions may also be used if pain limits the patient's ability to mechanically clean their teeth. So you would also be prescribing these to the patient to take home, and you can also try to irrigate or clean that area by flushing chlorhexidine mouthwash or the hydrogen peroxide solution. And you need to prescribe antibiotic therapy. So previously we studied that for either for gingivitis or periodontitis, we are not prescribing any antibiotic, but for necrotizing gingivitis, you need to give the antibiotic. Okay, and analgesic, because the patient is in pain, so you need to treat his pain and advise him to stop smoking, because that is the main reason for the necrotizing gingivitis, because here it is also written that it is more commonly seen in young adult smokers. Okay, so the risk factor for this is mainly if the patient is not maintaining his oral hygiene in a good way, and stress, and smoking, and if he's the nutrition is also not good. So these are some factors that can lead to this condition. Then profoundly immunocompromised patient. So which are the profoundly immunocompromised patients? So if the patient has end stage liver disease, end stage kidney disease, HIV, or if he is taking corticosteroid therapy, so those are the patients which are profoundly immunocompromised. Or if the patient has severe cases of necrotizing gingivitis, that may require prompt referral for specialist in addition to the management above. So even for those patients also, you would be doing these 5 points, and after that you can just refer them to the specialist. Then which antibiotic you need to prescribe, which is the metronidazole, because this antibiotics would work against anaerobic bacteria, and the dose is 400 milligram orally, 12 hourly for 3 to 5 days. And if there is any pain and inflammation may restrict the oral hygiene practices, then you can prescribe the short-term use of mouthwash, which you can prescribe either the hydrogen peroxide 3% solution, or you can prescribe hydrogen peroxide 1.5% solution, or chlorhexidine 0.2%, or chlorhexidine 0.12% solution. And you need to tell the patient the dose, how much they need to use, for how long, and do they need to swallow or spat out, and how many times. Then review the patient in 48 to 72 hours. It means you need to see your patient back in 2 to 3 days, and on that appointment perform a periodontal examination, like perform a thorough examination with the periodontal charting and with the probe, and provide the patient with the advice on oral hygiene. So advice on oral hygiene you are not providing in this visit, but you need to provide it on the second visit. And perform thorough debridement as soon as possible to prevent recurrence, because here the patient was in pain, so we were not able to provide complete debridement, but on the second appointment you would try to your best to complete the debridement to prevent any recurrence. And if even after doing this treatment there is a poor response to the treatment, or recurrence of symptoms is usually due to inadequate debridement or a lack of improvement in oral hygiene rather than ineffective oral antibiotic regime. So even if this does not help the patient, so the reason could be either you were not able to clean the area properly, or the patient is not cleaning the area properly, rather than putting the blame on antibiotic. Okay. If the infection has not responded to appropriate management, what is your management in this case is complete debridement, antibiotic therapy, improved oral hygiene, and even after doing these steps, the patient is not responding, and it's been 2 weeks now, then refer for specialist management. Treatment failure is usually due to inadequate debridement or poor oral hygiene rather than ineffective antibiotic therapy. Then periodontal abscess. A periodontal abscess most often occurs in patients with pre-existing periodontal disease or in those who are immunocompromised. So the periapical abscess, which starts from the tooth where the nerve got infection and pulpitis and all those things, that is more commonly seen as compared to periodontal abscess. And these abscesses generally happens in the patient who already has any pre-existing periodontal disease, or the other case could be that he is immunocompromised, which may be that he has poorly controlled diabetes. Symptoms include, because there is an abscess, so there would be any pimple on the gum or the swelling on the gum, and there would be discomfort. Pain is often difficult to localize and is not severe enough to interfere with sleep. So with the periapical the patient can localize the pain. Patient can localize the pain, but with the periodontal abscess, it is very hard for him to localize the pain, and it is not that severe that it can interfere with the patient's sleep. It is important to differentiate a periodontal abscess from a periapical because the treatment would differ, right? And we will see the location of periodontal and periapical abscess. And for the if the patient has periapical abscess, we will see in this page 81. So here they have shown in this diagrammatic picture, like 3, it is gingivitis. Okay, so from here the thing has started, then slowly it has involved the bone. So now there is periodontitis. Slowly bacteria started destroying all this area, and now they are sitting here and they are causing abscess. So it is periodontal abscess. Okay, so this is the area for gum issues, and if there is any tooth related problem, it would be like this periapical abscess or periapical inflammation. And this is periocornal infection, and if there is any third molar related abscess, so it would be pericornal abscess and it would be formed here. All right, so coming back to the management of periodontal abscess, it includes, first of all, if there is any abscess, it means there is a bag full of pus there, so you need to drain it, right? Drain the abscess with the local anesthetic through the periodontal, and the drainage would be through the pocket only. Do not incise or do not put a cut with the blade on that area. Just try to clean it through the pocket beneath the swelling, or less commonly through an incision in the external surface. It is done, but in very rare cases if you need to give the incision. And you have cleaned that area. What you need to do is removing the plaque and calculus deposits through with the thorough debridement, because that is the cause. Plaque is the cause which is causing periodontal abscess, so you need to remove that, and you need to irrigate the area, like flush the area or clean the area with water, with saline or LA solution. In severe cases, tooth extraction may be necessary to drain pus adequately, followed by thorough irrigation and curettage of the socket. Like tooth extraction is done in very severe cases because you need to drain the pus adequately. And specialist management is required if a periodontal abscess does not respond to local intervention. So like the treatment is generally very simple, so they have given you these points which you need to perform as general dentist. Even after doing this treatment, still your patient is not responding, then what option you have is the specialist management. If the patient is profoundly immunocompromised, treat as for spreading odontogenic infection without severe or systemic feature. It means if the patient is immunocompromised, profoundly immunocompromised, then you may need to prescribe him the antibiotics. We will read the spreading odontogenic infection in the next chapter, then the things would be much clearer for you. And in the rare event that a periodontal abscess has spread into surrounding tissues or caused systemic signs and symptoms of infection, it should be treated as odontogenic infection. So it is very rare for a periodontal abscess to spread into the nearby spaces and cause the infection. But if it happens, then you need to treat as odontogenic infection, that we will read in the next chapter. Then the peri-implant diseases. So the peri-implant diseases are caused by plaque accumulation. So everywhere the main culprit is the plaque. Here also plaque, here also plaque, in nug also plaque. Everywhere the plaque is the thing which is helping everything to happen. Okay, accumulation around an osseointegrated dental implant. And the peri-implant diseases are divided into two parts, which is the peri-implant mucositis, which is similar to gingivitis, and the peri-implantitis is similar to periodontitis. So in peri-implant mucositis, it would involve non-destructive reversible inflammation of the soft tissue, same as gingivitis, right? And the peri-implantitis, it would involve the destruction of the bone support of the implant and can lead to the loss of the implant. So if the patient has peri-implantitis, it means you can see in the x-ray that there is a bit of bone loss around the implant. Then there is a potential that he may lose that implant if he would not do any treatment, or if there is any option that the specialist can offer to him. Peri-implant disease is more likely if the dental implant is not professionally maintained or if a patient smokes. So, what are the causes for the risk factors for the peri-implant diseases? Is firstly, because for the implant, for the general public also, it is generally recommended to visit your dentist every 6 months. But for the implant patient, it is very, very necessary to visit. Okay, for the professional clinic, and if the patient smokes, that would increase the risk, and if he has already has a history of gum issues, has poor oral hygiene, and still he is not bothered to clean his teeth or gums, or is unable to clean their implant, or there is something like he does not know how to use super floss, or he does not know how to specifically clean around the implant. Peri-implantitis is associated with excess cement or poor fit, or if the implant components are poorly fitted, so it means it would increase the risk of food accumulation in that area, which would attract more bacteria, and that could lead to peri-implantitis. So these are some of the risk factors for the peri-implant diseases. So how would you manage it? If the patient has peri-implant mucositis, then what you need to do is non-surgical debridement, because it is similar to gingivitis. So it would be only the non-surgical debridement of the implant, providing advice on improving oral hygiene and smoking cessation, because smoking and implants does not go hand in hand. Encouraging regular dental review, including maintenance of the implant. And there is no antibiotic required for the peri-implant mucositis. For the management of peri-implantitis, you need to do these three steps, which are non-surgical debridement of the implant, which you would can do if you want to do, or providing advice on improving oral hygiene and providing advice on smoking cessation, and encouraging regular dental review, including maintenance of the implant. And in addition to these three strategies, the following interventions are often required, which would include surgical intervention, surface decontamination with or without hard tissue augmentation, soft tissue grafting, antibiotic therapy, specialist referral. Despite appropriate treatment, some implants will show continued bone loss and require removal. So, even after doing these treatments, some implants may require removal. For antibiotic therapy or for peri-implantitis in conjunction with other interventions, consider using amoxicillin 500 milligram orally 8 hourly for 7 days. So these are only antibiotics which are prescribed for 7 days. Other than these, generally the antibiotics are prescribed for not more than 5 days. Plus metronidazole 400 milligram orally 12 hourly for 7 days. But if the patient is hypersensitive to penicillin, then you can prescribe him only the metronidazole 400 milligram orally as a single drug. So with this, we have completed our periodontal case. And now tomorrow we will start with the acute odontogenic infection. It is very, very important chapter. I feel all the chapters in TG are very important, and you may get in one scenario from any like each chapter, and some of them do have higher weightage. So yeah, so try to, you know, revise with time. Even you can listen to the videos once again, or try to revise it so that you won't forget. And TG is a thing which you won't get in one go. You need to put your efforts. You need to spend some time, because this is the main thing. Even the dentists who are practicing in Australia, they also refer to the TG also, or TG only, because this is the main point where how you need to work in Australia. All right. Then I'll see you guys tomorrow, and thank you so much for watching my videos. Yeah, bye bye.